The consequence of that deal or no deal, increased acute pressures, poor access, revolving doors, mundane stuff. I've put it there because it's real. This is an important one for me. If you don't know what's in the community, you do one of three things. You send a referral inappropriately to a service, now my admin time has been wasted. Okay? Productivity is one of my specialities, so I don't like admin time being wasted. Or you don't refer them anywhere. So you get onto the GP, and the GP says, oh look, just go to A&E actually, because I don't have a clue where to send you in the community. We have NHS Direct, which is a national phone-in service, which they say, there's nurses on the end of the line, this is how I'm feeling today, this is what I think is wrong, what do you think I should do? Go to A&E, it's the easiest. Okay, or they do salvo referrals. I don't know who to refer to, so I'll refer to everybody, yeah? And so now the diabetic team is saying, why have they referred me somebody with back pain? You know, maybe they have diabetes, we'll see them. Just in case. So now I've got a patient who's registered with 20 of our community services. So now it's not just my admin time that's being wasted, it's my clinical time being wasted, it's my consumables that are being wasted, it's everything. We get the wrong patient in the wrong place at the wrong time, seeking the wrong service, and I hope to a much lesser degree getting the wrong treatment. But you can see from the picture here, you know, standing very nicely, thinking this is a nice snowy day and I'll taste the snowflakes, and not really understanding what the situation is above. How can we design a system that will allow us to ensure that patients can access community service from any given point that will ensure that they receive the right intervention, thereby improving access and response and decreasing the use of acute services? This is not about designing a system where they go from GP to acute speciality consultant. But you'll see later on in the presentation we've taken that into account. This is about, I operate £100 million worth of community services and I want everybody to be able to access them properly, quickly, and at the right time. Here are our constraints. So that was our research question, how are we going to do that? We've no money. I might have a board or staff who are saying, do you know, why would we bother? If we've enough work to do already, why do we want more work coming in? Because in 5 years' time, you won't be an organisation if you don't. Because in 5 years' time, all the money will have drifted to the acute because we're not attracting the investment, because we're not providing the services. So if you want sustainability, you better do it now. Risk aversion. We talked about this yesterday in terms of e-services. You know, everything has to be embedded in a 100% guarantee that nothing will ever go wrong. Well, that doesn't happen ever. You've got to assess the risk appetite of your board and your organisation to say, yeah, things might go wrong, but we'll have done as much to be able to predict that and to stop as much of that as possible, but we can't guarantee that everything is going to be right. We can't guarantee. People die, unfortunately. So if you're going to say, we have acute services in the community, we have a rapid response team that will respond to you within 40 minutes of your phone call, you will have a paramedic and or a nurse out in your house, not to bring you to the acute, to deal with you in your home. Well, somebody will probably ring and describe a symptom that seems okay, but by the time they get there, they've had an MI. That's not because the service is wrong, it's because, unfortunately, those things happen. So risk aversion is a big thing. And commissioner expectations. What did they want from us? We had to keep that in mind. So this looks impossible, but so does this. This diagram shows you a triangle with 4 separate components. This triangle shows you exactly the same 4 components. By rearranging the exact same components to give you the exact same overall shape, which I would say are your commissioner's expectations, you've created a whole. This is what we do. This is 1 + 1 = 3. And here is your benefit. Yes? So finances are a constraint. How do we use them differently? Risk aversion, how do we deal with it differently? Complacency, how do we work the board to not be complacent about this? And when you do that, you create this. Is it a fundamental change to your business? No, it is not. But has it created something? Yes, it has. And how do we exploit that? So our objective was that we would have the right patient in the right place at the right time, having the right service and having safe, appropriate treatment. We would use the correct technology, configured correctly. We would interact between our services. We would move away from, sorry, we're the diabetic, dietetic team. Okay. As opposed to the obesity dietetic team. Okay. You sit in the same office. Yes, but we're different. Oh, okay. So we were going to break down those barriers, okay? We would have correct service operation. What I mean by that, you said single point of access, this is exactly what it's about. But the single point of access has to work right. Same way as your bed management teams have to work right. So the internal bit of that, we would use change management and leadership. Bring the people along with you, but make sure that they understand that this is really important. This is the end point is not up for debate. The journey is up for debate. But we are going to Canada next winter skiing. Don't challenge that. You can tell me how you'd like to get there. You can tell me what you'd like to pack in your bag, but we're going skiing in Canada next year. That's the end of it. You'll notice this is an Irish slide, okay? Because these letters don't equate to those words, okay? But PDSA for me is plan, do, study, act. We all talk about vicious circles all the time. This is a nice circle. This is a lovely circle as long as you keep going round. Here's our 3 boroughs. How do we connect community care with our specialist services, with the acute hospital when it's required, with acute community services? And I'm very lucky. I have a 24-hour district nursing service. So all day and all night you can refer to them. I've got an 8 in the morning till 10 at night rapid response team. So I've got a huge infrastructure of services. And that's not a fluke. We've worked really hard to invest in the right places. But no one is using them. I trust my GP colleagues. I trust they'll make the right decision. They can only send them to the services when they know they exist and they know how to get them in. A basic operation in phase 1, phase 2 was service interaction. When I say basic operation, it was configured, it was possible. Service interaction, it was being used. Phase 3 was referrer interaction. So the first thing we did was referrals between teams. And then we did external referrals coming into the system. But we had ironed out a lot of the problems at that stage. Bed matching from acute to community, we have done. So if you're in the acute trust, our case managers, if they need you to get into a community bed, they'll use Strata. They don't use it for residential and nursing home beds, but we have approximately 150, 200 community rehab beds in our trust. And then phase 5 and beyond, which I'll talk about. This is the design of our solution. Remember you had your community services on the deal or no deal? So this is what here is. And this is our single point of access. Using the Strata Pathways platform and a team, which I'll talk about here. And that is your single access point for every single service that we provide to clients. There are none that you don't refer through there, except child protection. If you're a GP and you suspect child abuse, there is a process you go through. We didn't want to touch that. This is the design. So tell me what you think this team looks like. Who's in it?
Clerical.
Clerical? Yeah.
Someone to triage or assess.
No. And I'm really pleased you said that, and it was a trick question, so I apologise now for that. Sorry, that was Irish guilt coming out there. I was thinking, oh no, I shouldn't have asked that question. No. Clinicians? No. Manager? Yes. So I have 4. In the NHS, there are 9 grades of staff for everybody, unless you're an executive director or chief executive. Band 1 to band 9. And that's consistent across the entire country. Band 1 tend to be your domestic, and most domestic staff are band 2. Band 9 is associate director, nurse consultant, etc. I have 4/5 sometimes band 2 staff. So the second lowest paid staff member in the NHS runs this service for me. Okay? So you can imagine the costs of that are exceptionally low. So these don't have clinical qualifications. So what do you have to do?
Build the decision support into your system.
Absolutely right. Okay? And that for me is why Strata were the right partner. There was not another system that we could use. What we did, we spent a long time making sure that their configuration went into the system so that the system became the decision support tool. So that when the referral came in and got pumped into the system spat out the team. Okay? And the system said, you need to refer this to the spinal musculoskeletal assessment team. And then the referral went electronically. It was not the staff. I wasn't going to let my patient's care be determined by mood or by waiting time or by pressure within the service. That's not how you determine the right care for a patient. You determine the right care for a patient by getting them to the right service.
It's a forced action.
You can't use anything else. So what did that say to the service leads?
I must conform.
Right, okay. And if you want to get referrals, then you better spend some time with ClinCheck. Because there will be a cut-off point where the information that you've given us is the information that will be in that system. And if it's wrong, you're going to get the wrong patients. And if you get the wrong patients, I'm going to sit with you and I'm going to say, you're going to come into my office and you're going to say, bloody SPA, I keep getting the wrong patients. Why? Well, because they just seem to be, why? And as I keep asking you why, eventually you'll say, because I didn't spend any time with ClinCheck, at which point I'll take your legs off. So I suggest that you do that now and not get into the situation where I'm asking you the 7 whys. Okay, do it now and get it right. And actually, Clint, I think it's very fair to say that staff conformed to that, partly because it was a forced action, partly because they could see the benefit, and hugely due to the change management skills of the Strata team, who were actually able to engage in that level of conversation with the staff to get the stuff in. There's another reason we did it this way, and that's going right back to the constraints that we had. Financially, it was cheaper, because if you don't do it with the technology at the centre, then you're having your clinicians there. How many in the audience are clinicians? Okay. Did you train as a clinician to sit on a telephone line? Right, okay. I didn't either. Now, that's part of the course now, but I didn't want my name to be associated with de-skilling clinicians. Okay? So I only have a finite number of clinicians, and I want them out there doing the best they possibly can, patient-facing time as much as possible, recognizing that people choose a management career route. But if you didn't, if you're choosing a clinical career route, I don't want you spending time on the phone. So that was one thing, but financially, it worked out better. Okay? And the other thing is risk aversion. And you mentioned it. This forced my board into submitting to the fact that you're letting a computer system decide. Yeah, but we're doing all this. But a computer system is deciding where the patient goes. Yes. Will it always get it right? No, it won't get it right. But there are certain patients, and the form is designed to pick up the urgent ones. And if there's an urgency there, the first people who will see the patient is the rapid response team, and they know what to do. So don't worry about that. And actually, that was really important. It changed the culture of how we did things, and it was an important one for us. I've got some great GP colleagues. I've got some very entrepreneurial GP colleagues, which in my view are the best. They're part of the NHS family when they need to be, and when they don't need to be, they're businessmen and women, and that's fine. So the entrepreneurial ones are the ones who are saying, there's a trick we're missing here, and they're great to talk to, okay? So when we were designing this, I went and I spoke. We've got about 15,000 local committees associated with primary care. And we went and spoke to every single one of them, I think. For the past 10 years, you've been saying to us that the community referral system is far too confusing and you want it simplified. So guess what? We're simplifying it. Oh, we kind of like it now. Well, tough, as they say in Dublin, because we're going to change it. So we came to them and we discussed it with them, and they were very open to it. And we said to them, so how would you like it to work? And one GP said, I want it so electronic. I want to sit there in front of the patient and I want to think, he should go and see community services and you will get the referral. That's how modern I want this. Down to, well, could you print off a piece of paper and laminate it for me, and then I can stick it in front of my desk, because that's how I like to do it. Okay. To the, we want to see the directory of services. Can you put that online? Yes. To the, can you print me off a book every 6 months? So there was a huge range of wants with the GPs. So we decided we're going to meet them all. So here is a single telephone number, a single fax number, a single postal address, a single email address, and an automatic online referral form that can be clicked and sent.